normal
of the adult thoracic should start from. They say from different direction. You can start wherever you want, wherever you can access the best image, but you need to look from different areas. Some of them recommend start from the left parasternal and then go to apical, then subcostal, or you can start from subcostal, apical, parasternal. Okay, but look from all directions. So how do you optimize the image? You can do like adjusting the gain. Okay, sometimes it becomes whole things become white, so you need to decrease the gain, or sometimes to happen all black, so you need to adjust that. Time gain control is a different area. Alone gain on adjust on different sides. Okay, different sides. Like it's from the proximal or distal, you need to adjust that. Depths. Okay, depths until you see the posterior pericardium. Okay, you need to see the whole pericardium. Focal zone is the focus. Where do you focus? So there is some cursor in the ultrasound. So that's the focus. What is your focus area? So you can do this to optimize the image. Okay, you can have a better image. So these are the main things that you are expected to do in the emergency. One is effusion, second is effort, so third one is equality, fourth is exits, and the fifth one is entrance. They call it the 5 E's. So effusion, is there an effusion? Yes or no? Okay, a simple question. Yes or no? If there is it significant or is there tampon? Okay. Effort is the left ventricle functioning. That means is the patient in cardiac arrest, or how is the global function of the left ventricle? Equality, you will check the right and the left. Okay, normally, the right ventricle and the left ventricle are different. Exit, you look for the thoracic aorta, especially the outlet, for aneurysm, and the entrance IVC. Okay. Was it collapsed, was it pleuritic, or was it normal? So these are the 5 questions you need to ask in basic echo. So these are the very basic things you can't do, but they can determine the life of the patient. So let's start from fission. You know, like there are different classifications actually: small, moderate, large, very large. Measuring the diameter of the pericardial effusion from the pericardium to the posterior. So if it is very minimal, less than 1 millimeter, so 1 centimeter or more than 2 centimeters. So the size sometimes will determine the clinical status. Sometimes, if it's an acute, yes, it will determine the hemodynamic status of the patient. But if it's chronic, a very large pericardial effusion will not lead to tamponade. So we need to decide on just on not only the size, but the clinical status of the patient. So what view is this? Yeah, it's already written. Along, so you see, left ventricle here, the right ventricle here. So which probe is used? Emergency view or cardiologist view? Why? Yeah. So the LA will be on the LV side, but the left ventricle will be here. Okay, you look like this. So what do you see? What is the effusion? Yeah, over here. Okay. So sometimes, yes. Yeah. No, this is not the pericardium. It looks pericardium, right? Where is the descending aorta? Yellow. So? Yeah, it looks, this is a pericardium, huh? Yeah. I think it's the muscle that looks thick. Because you don't see the descending aorta here. Okay? So, because it's more of anterior to the descending aorta. So the thing is, if it is posterior, it's easier to identify whether it's pericardial effusion or not. But the issue is if it is anterior. Okay. So small anterior is difficult to differentiate. So you need to rule out whether it is pericardial fat part. Okay. Pericardial fat part is a differential for a very small pericardial effusion on the anterior part. So if it moves the whole direction and then cross the apex, then it's most likely is pericardial effusion. Okay, the pericardial effusion. So you look and then look for the movement. If it is moving with the heartbeat, it's more of fat part. Okay. What about here? Apical four chamber. Finding right and left atrium, ventricle, and pericardial. Okay, pericardial. Parasternal, short. Which level? Is lower down. Where is the mitral valve? There is no mitral valve. Papillary middle. It's going down the apical. And then you see the effusion posteriorly. What the problem you see here? What is this? This one. This white hyperechoic. What do you call it? These are very basics now. So you need to. What will happen if you scan a patient with full bladder? What do you see? What will happen to the posterior? Can you see a prostate? What do you call that? So you call that acoustic enhancement. Posterior acoustic, because there is anteriorly fluid, so all the beams will go down and then it will be absorbed. Okay, so you need to adjust the gain to see whether there is something here. Here, which view? Apical. Yeah, so far. Sometimes wrong grenades. Subxiphoid, right? So right, left. Which one left? Right atria, right ventricle, and this one. And look here, it looks like RA is dilated. The problem is a view, okay? Yeah, is a view. Okay, so the fluid is significant, right? So you can measure it. It looks more than. Okay. Echo features, RA and RV, diastolic collapse. Okay. So the RA free wall moves towards the RV cavity early in diastole. And RA moves towards at the end, RA moves inward at the end of diastole and at the beginning of systole. Okay. So what is the first to happen in a tap point? You know? Yeah. So the RA followed by RV. The first to collapse is R. So why could they call it diastole? Because during systole you expect them to collapse. So this is from external force, they collapse. So they need to distend during diastole, but they will collapse. Good to know? So as you see here, the RV will collapse. Okay, it's like a swing. So you see here the RV is collapsing. Here, RAs collapsed. Is that?
This is the first.
Why do you think? Because it was missed. Because you can't see it, you can't detect it. This is physiology, not like you can't find it when you can't see the RA collapse. Because you don't see the RA systole, the RA diastole at time. Okay. What is easily visible is RB collapse. And significant effect is on the RB collapse. Okay. But you see, the problem is you need to understand the pressure difference in the atrium and the ventricle. Okay. Which one is higher pressure? Is the ventricle, that from right and left? Left, right? And then from right ventricle and from right atrium is the right ventricle. Okay. The easier to collapse is the atrium. Okay. So what do you see here? Yes. RB collapse, significant RB collapse. Which view is it? LV also. It passed to the LV. The pressure goes to LV. This is parasternal. Subxiphoid. It's subxiphoid. Okay, so echo can be used for guidance. You can confirm the diagnosis, and you can also locate the best site, whether to go apical, parasternal, or subxiphoid. Okay, you look the deepest pocket, and then you can direct. You can confirm the success of the procedure. Second is effort. Okay, stand still. So it's used to detect cardiac arrest. Okay, you can also confirm stand still. What's stand still? Stand still. So sometimes you can also look for lack of organized cardiac activity, and sometimes you can also find treatable cause for PA. You think of the 555Ts, you can think of tabloid hypovolemia massive PE, and be considered by using ultrasound. Nowadays, also they are saying there are a very small ventricular fibrillations can be detected by ultrasound, which has missed by defibrillator. Okay, so you can look and then shock and the liver. So this is cardiac standstill. You place on the heart, and then you make an EMO mode, and then you see a flat line. So this is cardiac standstill. Another is ejection or injection fraction, or how is the squeeze. The normal ejection fraction is from 60 to 70. There are different reports, but go higher up. Some say 55, some 60. Yeah. So you can calculate by in diastolic volume minus in the systolic volume over 100 over in the diastolic volume times 100. So it's the volume, not the diameter. So you can also use the visual estimates. When you become more experienced, you just look how is the contractility, and then just ejection fraction is 20%, 30%, 45%. Okay, significantly depressed or moderately depressed, or normal or hyperdynamic. Okay, sometimes you don't need to just always write the number of ejection fraction. You just see. We call it eyeball method. So dimension-wise, you already discussed earlier. You measure different dimensions. So the ultrasound or the echo will determine the ejection fraction if you give him this report, like the interventricular septum during systole diastole, LV systole during LV diameter during systole, posterior during systole, LV diameter during diastole, posterior wall during diastole. So if we give this report and then MMO measurement line place then you can calculate the ejection fraction and stroke volume and others. Okay, can be calculated. But the eyeball method is recommended, especially in the emergency. So one thing that you see is how is the contraction of the left ventricle. So the left ventricle should contract to the middle. So this is a left ventricle, then it should contract to the middle. Okay. So that means it should contract to 55 to 70% or 60%. What is 60%? So if it's contracting like this, it's more than hyperdynamic. Okay. So if it's coming halfway of the 50%, then it's moderately depressed. If no moving, it's severely depressed. So you can look from the direction. So let me say, if this is a normal endocardium or the ventricle during diastole, then if it contracts to the height level only, then the ejection fraction is 10/50. And if it goes to like this somewhere here, then it becomes 20/30. And if it comes to the pink level, then it becomes 75. Okay. And the other thing you should see also is a mitral valve. Okay. So the mitral valve should touch the septum, and the interventricular septum should thicken during systole. Okay. Interventricular septum. So one is the direction, two, the interventricular septum should thicken, and the third one is mitral valve should touch the septum. Clear? Equality. Equality of right and left. Right ventricle greater than left ventricle. The normal RV pressure during systole is 25, diastole is 10. The normal RV to LV ratio is 0.6 to 1. If it's greater than 1 to 1, it's specific for RV strain. If it's just 1 to 1. So the normal right ventricle should have a thin wall. And sometimes RV hypertrophy can also be diagnosed if the thickness is more than 5 millimeter thickness. So from short axis view, you see it should look like C-shaped. Okay. And long axis view is almost triangular. Okay, like this. If there is abnormalities, then this will be enlarged, or it will press the left ventricle, or it will push the left ventricle, and sometimes becomes LV will become D-shaped. So if there is strain, there will be paradoxical septal motion. RV will be hypokinetic, and in PE, apex is spared. It's more of a mid. What's McConnell sign? Interventricular septum. So McConnell sign is extreme pressure of the right ventricle leading to pressure to the left ventricle. Okay. It's a sign of PE. Okay. Apex is spared in PE. In addition, is another sign is a McConnell sign. Exits, you know the exit. No, you don't see the exits. Thoracic aorta, you can use parasternal long axis. Okay, parasternal long axis. You have the aortic arch. So you can measure from the outside from to the inside. The normal is less than 4 centimeters. If it is more than 4, there is dilation. 4.5. Thoracic dilation is a strong indicator for dissection. But you know, like all dissections, all aneurysms will not dissect all dissections are also not aneurysm. So you see here, what is this view? What? Okay, so the probe direction is here. This is the left ventricle. What is this? What is this? So you measure here, okay? So you measure here. So you measure here, and if it is more than 4.5, it tells you higher up there is some. Entrance is IVC, it's common for you, so I don't go in detail.